Well, thanks everybody for coming, especially those of you that are not abdominal people. I apologize for all the bowel in this talk. So I was just going to talk a little bit about small bowel CT tonight. I have nothing to disclose. And I thought I'd split this up into three parts. And there are three areas where there's been a lot of action in bowel CT over the last few years that I thought might be interesting to review, and that's mesenteric ischemia, using CT to assess acute GI bleeds, and then CT enterography with some subheadings there. So starting off with acute mesenteric ischemia. About 30 to 40% of cases of acute mesenteric ischemia are related to arterial emboli, as you can see here by the yellow arrows. Another 20 to 30% are related to primary arterial thrombosis. Here the SMA is occluded on this lateral aortogram. A further 20 to 30% of cases are related to low flow or non-occlusive ischemia. And here, this is a patient who had that and then is in the reperfusion phase. And you can see there's these multiple small bowel loops that are mildly thickened and hyper-enhancing. That's kind of paradoxical when you think about ischemia. Why would you have hyper-enhancing bowel? But we'll see why that occurs in just a second. And then finally, 5 to 10% of cases are related to mesenteric vein thrombosis. And here, this yellow arrow is, of course, showing us that the SMV is thrombosed. Now, going forwards, I'm going to be referring repeatedly to clinical suspicion for acute mesenteric ischemia, and in fact, that's actually a defined thing. So in the literature, the clinical suspicion for this is defined by one of three presentations. If you have pain that's significantly out of proportion to physical findings, abdominal pain with biochemical evidence of ischemia, especially elevated lactate, or abdominal pain with specific risk factors, those being things like prior abdominal ischemia, significant vascular disease, atrial fibrillation, a hypercoagulable state, or a clinical hypoperfused state. So let's talk about what happens in this condition. And I am no artist, but this is my rendition of a normal bowel loop and a happy red blood cell that's perfusing it to start off with. So in inflow ischemia, and by that I mean ischemia where you've got an embolus or a thrombus or a low flow state that's reducing the flow of blood to the bowel. So there we go. The first things that happen to the bowel is an ischemic ileus develops and it dilates, and the wall will become hypoenhancing because the iodine that we're giving isn't going to get there. Now, eventually, the ischemia will become transmural. It starts in the mucosa and extends outwards. And once the ischemia is transmural, you get fluid weeping from the bowel. That leads to mesenteric edema. That piles up and leads to ascites. As the disease progresses, eventually the mucosa breaks down. That leads to pneumatosis. That air gets into the mesenteric venous system and eventually the portal venous system. And eventually the wall may completely break down and you can get frank perforation. Now, if we manage to reverse the inflow problem before gangrene sets in, then we enter what we call the reperfusion phase. So here, when you reperfuse the bowel, you see bowel wall thickening and hyperenhancement. And the reason for that is the ischemia incites an inflammatory reaction within the wall. So that makes sense. You've got hyperemia, you've got more iodine reaching there, and of course the edema is making the wall thicken up. And you'll notice that up until this point I haven't really talked about wall thickening, and that's because usually in inflow ischemia, wall thickening is not really a predominant finding, especially at the beginning. It's a late finding if it occurs at all. So let's go back to our normal bowel loop, and now let's talk about occlusion of venous outflow. So when this happens, because of congestion, wall thickening is actually a prominent and early finding. If you have some venous outflow persisting, you might actually get a hyperenhancing wall, but if the venous outflow is really obstructed and occluded, then you may get hypoenhancement because that will eventually transmit pressure back and affect inflow. We're going to go back to the beginning now and then interleave our imaging findings and see where they fit in. So first of all, arterial inflow ischemia. The first thing we will see before there are any bowel changes are CT angiographic abnormalities. So we'll see the embolus, we'll see the thrombus, or we'll see CTA signs of non-occlusive ischemia, and the bowel can look completely normal. I stress this because looking at the CTA is really an important part of assessing these cases. Here you can see there's some emboli in the SMA arcade. So what we're looking for here is vascular occlusion, be it thrombotic or embolic, vascular stenosis, and for our purposes, we're talking about a stenosis that is greater than 75% if it's going to be hemodynamically significant, or findings of non-occlusive ischemia. Now, the ones that you usually will see are a very small SMA diameter, typically 4 millimeters or less. That's been reasonably established in the literature as a decent sign, or impaired filling of mesenteric branches. So it looks like the mesenteric vascular arcade is pruned. You might see narrowing of SMA branch origins or spasm or beating of the mesenteric arcade. These are classic catheter angio findings. They're a little bit harder to see on CT because of the limitations of CTA resolution. Now, of course, you have to look at the source images, and any abnormality you see on reformations, you need to correlate back to the source images to make sure that it's not an artifact. But it's impossible for our brains to wrap around all the different branches of the SMA and the IMA on source data sets. There's just too many images. We can't follow it out. So you have to do some kind of 3D reformation. You can do volume rendered images. I really like maximum intensity projection reformations, but they come with a pitfall because, of course, they're projecting the brightest pixel in that volume up to the front. So if you have a thrombus or embolus in the vessel that's not completely occlusive and you have iodine on either side of it, that iodine gets brought to the front and could potentially mask a subtotally occlusive clot. So if you're going to use these, sure, look at them thick, but then make sure you thin them out. Whatever you do, don't get your technologist to just send you a stack of sliding thick MIPS or something like that, because that's asking for trouble. Curved planar reformations are useful, especially if you're looking at something that's in the proximal vessel, because they usually come with automated double oblique reformations that let you look down the barrel of the vessel, get an idea for how much of the lumen is actually narrowed. So this is what I do. I'll go to the workstation and thicken and thin out my MIPS, rotate it around a little bit. The lateral aortogram view is kind of nice for looking at the origins of the SMA and the celiac. I will make volume rendered images as well, but I have to say I do a lot of my interpretation of the CTA playing around with the coronal MIPS and spinning them around. And again, you see a lot of abnormalities when you really look closely at the CTA, so it is really important. This is a couple of patients with non-occlusive ischemia, demonstrating the more common findings that you will see. So this one here, you can see there's just pruning of the SMA arcade. There's only a few branches visible. Those are fairly small, and on the lateral view you can see the celiac is in spasm. And then the second patient, that SMA is just a little pinprick. It's 2 millimeters. The ischemia in this patient was so bad that there was air dissecting through the mesenteric venules that you can see on this minimum intensity projection reformation. Okay, so let's say we don't see any of those CTA abnormalities, then we're looking for bowel changes. And again, the first ones we see are an ischemic ileus. Well, that's not super helpful because there's mild small bowel dilatation in practically anybody that walks through the door and emerge, so it's not going to tell you if there's ischemia or not, but the wall hypoenhancement is really, really important because this is something that doesn't happen in other conditions, and it is an early finding, and it occurs in a really reversible stage of ischemia. It's problematic though. And the reason is, if you recall, I said that wall thickening doesn't usually occur at this point. And if you just say, take a look at this patient and just take a look at these couple of bowel loops, the wall is really thin there. And I would say it is pretty hard to assess. If you gave me a cropped image of just these two loops, I honestly don't think I could tell you if that wall was enhancing normally or hypoenhancing. A thin bowel wall is one that is really tough to evaluate. What you need to do is find some loops in the abdomen that you really can convince yourself look like they're enhancing normally. And then once you've established a baseline for that patient, then go look around and see if you find ones that look different. So here you can see that we have some normal loops on the right shown by the yellow arrow. And then in retrospect, you can go look at these ones, especially where you see them in length, and you can appreciate that the wall just is enhancing in the same way. But again, this can be a challenging diagnosis. Another trick you can use is look for other findings that point you towards the abnormal loops. And one that is frequently very useful is mesenteric edema. So here you can see there's quite a bit of edema in the pelvis, and it leads us to these loops here, shown by the blue arrows, that are clearly hypoenhancing compared to the loops shown by the yellow arrows. Now, the same process that occurs and causes wall hypoenhancement in the bowel is the same thing that can cause hypoenhancement or frank infarction in the solid organs. And here you can see some hepatic and splenic infarcts. Now, of course, you can have solid organ infarcts without bowel ischemia, but studies have shown if you have someone who meets those clinical criteria for suspicion of acute mesenteric ischemia, and then you do a CT showing solid organ infarcts, assuming they don't look chronic to you, there is a very high chance that patient actually has emboli to their bowel as well. The association is there. Okay, so the ischemia progresses, becomes transmural, we get our mesenteric edema and ascites, and that's not super helpful because those occur in so many infectious or inflammatory conditions. But remember, the mesenteric edema might lead you to loops of bowel that show other more specific findings. So it's not completely useless. Okay, so the mucosa breaks down, we get pneumatosis. And pneumatosis is a really specific finding. If you have a patient population that meets that criteria for clinical suspicion of acute mesenteric ischemia, in fact, if you do meet that criteria, a lot of papers will tell you it's practically diagnostic. And a lot's been written about pneumatosis morphology, and it's true that bubbly pneumatosis is usually a benign finding. Curvilinear is usually associated with ischemia, but you can actually get either in either condition. So it's not really something you want to hang your hat on. What's important is, does a patient with pneumatosis, do they have symptoms or clinical suspicion of acute mesenteric ischemia, and is their lactate elevated? There is, in fact, a good paper out there saying that a lactic acid of over 2 millimoles per liter is very suggestive of ischemia if you see pneumatosis. There is the phenomenon of pseudopneumatosis. That's where little bubbles of gas get trapped between liquid stool and the bowel wall. It's not really in the wall, and the hallmark finding here is that the little bubbles don't go above the stool fluid level, or the stool air level. So if you get pneumatosis, that can get into the veins. And mesenteric and portal venous gas can, of course, occur in any transmural inflammatory process of the small bowel, such as Crohn's. But in this patient population where you have this clinical suspicion, it is an incredibly specific finding. Here you can see some air in the mesenteric venules shown by the yellow arrow, and of course portal venous gas shown by the blue arrows. Free air is not specific of ischemia at all, but it at least ends your search. In this case, you can see the pneumatosis shown by the yellow arrow, air dissecting through the mesentery shown by the blue arrow, and then frank free air shown by the green arrow. Okay, so now let's say we reestablish flow to that bowel before it perforates, and we enter the reperfusion phase. So that, unfortunately, starts to look a lot like any infectious or inflammatory enteritis. So you're left with a bit of a problem here. How do you know this is reperfusion ischemia and not something else? Well, sometimes you're lucky enough that you've done a prior. Unfortunately, this doesn't happen very often, but in this case, we had a scan at presentation. You can see there's abrupt occlusion of the SMA. There was an embolus there, clear hypoenhancement of the bowel shown by the blue arrow. And then the patient had an embolectomy, and afterwards, they have a fairly classic look for reperfusion injury. The wall is thickened, it's hyperenhancing, and there's some mesenteric edema there, but this is the exception to the rule. We don't always have that first scan clearly showing the ischemia. So what you need to do is look for other supportive findings of non-occlusive ischemia or the findings of shock abdomen. So aside from the bowel changes, you might see IVC flattening. That's written about a lot, but the fact is when we scan these patients, they're usually not acutely unstable and hypovolemic. They often just come to the CT scanner after they've been resuscitated. So I would not really rely on a small IVC a whole lot, but the arteries may still be small because the vasospasm can be persistent for a while. So that is a good finding, I would say. Gallbladder wall edema or mucosal enhancement you might see, peripancreatic fluid. I really stress hyperenhancing adrenals because this is something that happens fairly frequently and it's easy to pick up. So if you're thinking that the patient might have this reperfusion injury, really check the adrenals. And then the solid organs might be heterogeneously perfusing or infarcted because of vasospasm. So in this example, this patient had shock abdomen. You can see there's diffuse small bowel and gastric thickening shown by the yellow arrows. And here is our clue. The blue arrows are showing us hyperenhancing adrenals. And this patient was resuscitated after an episode of non-occlusive ischemia. Okay, going back to our normal bowel loop, and this time we get venous thrombosis. So in this case, really what we want to look for is the venous thrombus. And wall thickening, again, can be fairly pronounced and can be seen early on, which generally, again, is not the case with inflow ischemia. So finding mesenteric or portal vein thrombus in someone with the clinical suspicion of acute mesenteric ischemia is, again, one of those things that can occur without having bowel ischemia, but if you have that clinical scenario, the two are fairly highly associated, so you got to keep that in mind. Various papers would tell us that the specificity for that finding is fairly high. So we've gone through a whole bunch of different signs. Let's try and put them all together and talk about how we can make the diagnosis. and also a little bit about how we can optimize our protocols. So if you look at all the major papers done looking at ischemia over the last 15 years, you'll see that there is a big jump in the sensitivity of CT for acute mesenteric ischemia in the early 2000s, and that's related to two factors. So the papers that looked at this after that point all targeted patients who met that clinical criteria for acute mesenteric ischemia, the suspicion. Because they were targeting that patient population, they actually did a two-phase examination. So all those latter four papers did not only a routine portal phase abdomen, but also a CT angiogram. And it's probably that CT angiogram addition that really made that jump in the sensitivity occur. As it happens, all four of those papers were actually pretty much in agreement about what CT signs of ischemia are. So if you have somebody who meets those clinical criteria for acute mesenteric ischemia I mentioned earlier, the findings of any one of pneumatosis, mesenteric or portal venous gas, SMA occlusion, mesenteric embolism, celiac and IMA occlusion with SMA stenosis, or the CT angiographic signs of non-occlusive ischemia that I told you about, any one of those individually is very accurate in making a diagnosis. Alternatively, if you have any bowel wall thickening plus one of hypoenhancement, solid organ infarction, or venous thrombosis, you can be quite confident in making the diagnosis. Now, if you're like me, you look at that and think, well, that kind of doesn't make sense, because I just stood up here and a few minutes ago told you that hypoenhancement, solid organ infarction, and venous thrombosis are all pretty good signs. So why are we tying this to bowel wall thickening when I said that it often is not a prominent finding and certainly not an early one in arterial inflow ischemia? And it is problematic. The reason is, of course, because solid organ infarction and venous thrombosis are things that can both occur, and while they're associated with bowel ischemia, they don't have to be. So finding the bowel wall thickening with one of those two findings is kind of proof that they're having an impact on the bowel. And the two happen together enough that it works out reasonably well. The more problematic one is tying hypoenhancement to bowel wall thickening. And as one of the authors of those papers, I can tell you that the reason why that ended up statistically being a thing is because people tend to overcall wall hypoenhancement when there's thin bowel walls and when they know that there might be clinical suspicion of ischemia. By tying hypoenhancement to any bowel wall thickening, you essentially eliminate all false positives, but you do it at a significant hit to your sensitivity. So historically, the published criteria generally tie hypoenhancement to wall thickening, but this has always bothered me because I feel like wall hypoenhancement is such an important early finding. We should be able to diagnose it without relying on the wall being thick. And in fact, I often do. If I see it and I'm really convinced about it, I'll call it if I think that the wall is hypoenhancing. But it's made me think, what could we do to improve our ability to detect hypoenhancement, because it's so important. So the residents will recognize this. This is in our abdominal CT timing diagram here that we talked a lot about today. And historically, for the last 10 years or so, the classic ischemic gut protocol CT has been an early arterial phase for a CTA, and then a portal phase study, typically towards the latter end of that portal phase, because you want to get some uniform opacification of your venous system. In fact, these days, most people would say you probably want that second phase to be closer to the delayed or venous phase for that reason. Water is oral contrast. You don't want positive oral contrast that can obscure your bowel wall enhancement. And then you want IV contrast at high flow rates because you want to maximize the conspicuity of iodine in the bowel wall. But we've been doing something different lately, and that is, I thought, we do enteric phase scanning for CT enterography, and we see the bowel wall enhance really well. So why aren't we doing this for mesenteric CT? And basically what we did was we combined a CTA enteric phase by basically scanning in the enteric phase, but scanning with a contrast column that's long enough so you get an enteric phase scan where you still have a ton of contrast in your arteries. You get a perfectly fine CTA. The only potential disadvantage is if you're doing MIPS, sometimes the bowel wall enhancement might get in your way a little bit if you're assessing the vessels, but it's not that big a deal really. And it does give you, I think, a big boost in how much brightness you get from the iodine in the bowel wall. So this is what we're doing right at the moment. Water for oral, 160 cc's of IV. So you have to be a little bit judicious about when you're going to use this. If you have a patient with renal dysfunction, you might want to change that, and maybe you don't want to use this protocol. And then we do 4.5 cc's a second for 35 seconds with a fairly large saline flush. I don't know if that extra 10, 20 cc's of saline flush really does anything. It makes me feel better though. And then we do our second phase as a delayed or venous phase. But there's one other thing that we do here, and that's we acquire this with either dual energy or low kV, depending on what type of CT scanner we're using. And the reason I say that is because in a perfect world, if I had unlimited tube capacity, I would probably scan all these people with 80 kV and get really great iodine brightness. But the fact is, I have 3 CT scanners in my hospital. 2 of them are relatively older GEs that don't have a lot of tube capacity. And then I have 1 scanner that's new, a Siemens, that has a lot of tube capacity. But for those GE scanners, I can't do serious low kV scanning in almost anybody unless they're really thin. So even on our Siemens scanner, if a patient is of reasonably big size, 80 kV can be a stretch because we don't have the absolute latest and greatest. So, if you have a Siemens Force scanner and incredible tube capacity, I would say by all means scan with a really low kV, like maybe 80 kV, you'll get great results. And we do sometimes 80 kV scanning on our Siemens scanner in someone who's small. But what we're doing a lot of the time is a dual energy scan. And then you have 2 options. You can do virtual monoenergetic reconstructions, and they'll be really noisy when you do that. But if you're just looking for bowel enhancement, that's okay. And then you switch to your other images, your blended images, for looking at everything else. Or you can use one of these algorithms, the nonlinear blending, that basically it takes the high attenuation information from the low kV data set and the high attenuation information from the high kV data set, and the low Hounsfield unit attenuation data from the high kV data set. So what it's doing is essentially giving you brightness of iodine that looks like an 80 or even less kV scan with the noise profile of something that looks around a 100 kV scan. So Siemens has an algorithm, they call it optimum contrast, that you can use. GE is working on theirs, and they say it's gonna be out any minute, but it's not actually on the market yet, but it probably will be pretty soon. And that works out really well. It gives you a really bright iodine, but it doesn't actually really give you a big hit in image noise. So just a couple of examples of what these look like. So here's a patient who had C. diff colitis and was in a shock state. You can see on their CTA, their vessels look like they're probably in a bit of spasm, and you can see their colon's quite thick. But what I want to really stress here is look how incredibly hyper-enhancing those adrenals look when you use this kind of technique. And then this patient didn't have anything for oral. We didn't give them water. We definitely didn't give them positive oral contrast. That's just the iodine in the bowel wall making them look like that. So you can make them look really bright. And another patient here where you can see that the small bowel is super enhancing. That, again, no oral contrast. That's all the bowel wall that's enhancing. It's just relatively non-distended, so it almost looks like there's oral contrast in it. So this particular patient, they had an abrupt occlusion of a branch of their SMA, and you can see that right there. There you can see that branch vessel open, and there's the embolus within it right there. And I just want to point out how conspicuous the hypoenhancing bowel looks now compared to the normal bowel. So we've really brought out that difference. One more to try and convince you. So this patient had a chronic aortoiliac occlusion. Now they've got an embolus in their SMA. And if you take a look where the blue arrow is, you can see there's this short segmental area of poor mucosal enhancement right in here. And I honestly do not think I would have been able to appreciate this if we didn't do this kind of technique. We've got the contrast, the iodine contrast, cranked up so much. Take a look at the liver over here. It's just pure white because of the way we've reconstructed this. So we've really brought out these areas where the wall just isn't enhancing that well. So I really like this technique, and I just wanted to share that with you. Just one last comment. I know there's a lot of people write about using non-contrast scanning for this, and I think that's fine. The idea behind it is that ischemic bowel can hemorrhage in the bowel wall, and if you do a non-con scan, maybe you might see it. I think there's a very good paper in 2013 out of Ottawa that said, it probably isn't that great, the inter-observer variability isn't that good, and whenever you see that, there's always other specific findings on the infused cases, And I think I would agree with that. If you like doing that, more power to you. They're sick patients. I think you can do whatever you want to get a good diagnosis, but by no means is it a mandatory part of the CT angiographic study. I think you need a CTA and you need a portal or venous phase, but everything else is sort of optional. So just to finish up this first part of the talk, just to remind you that you really want to do at least 2 phases. I would advocate thinking about at least that combined CTA enteric phase. We found it really useful, and think a lot about whether you want to use dual energy or low KV. I know it's challenging if you have old equipment though, it really is. And then remember the more specific abnormalities that we talked about. Now, to move into phase 2, we're going to talk about acute GI bleeding CT. And you know, for a long time, people sort of dabbled in this. There was the odd paper that came out showing that, yeah, maybe CT would be useful for identifying a source of active bleeding in the GI tract. But things really picked up steam in this decade, around 2012 especially, when this paper came out looking at lower GI bleeds. And interestingly, out of 47 patients, they basically found that every single patient who went on to have angio or colonoscopy, the active bleed was identified by the CT they did beforehand. And that got a lot of people thinking, gee, maybe this is a good test. And in a lot of centers, this was added as part of the routine diagnostic algorithm. A year later, a meta-analysis was published that looked at a lot of cases where only a CT angiogram was done. And even with that one-phase exam, they actually concluded that it's pretty good. About 85% of bleeds are identified when you do a CTA. There's been a couple of other kind of key studies in the last couple of years. This Nagata one is big though because it gets a lot of play in the gastroenterology world. They compared doing colonoscopy right away in active lower GI bleeds to colonoscopy after you have a GI bleed protocol CT scan. And they found that if you do the CT first, they identify more bleeds on the colonoscopy, basically because they know where to look. Remember, these are kind of tough cases to scope. They haven't been prepped properly. There's blood there. So the CT helps them localize where the abnormality is, and they ended up treating a lot more patients. 35% versus 14% got treated endoscopically, and they concluded that, you know, maybe CT should be performed for all of these acute lower GI bleeds before you do the scope, which beforehand we would have thought was kind of crazy. In 2016, there was another paper published that was just looking at the utility of CTA versus red blood cell scanning. And they found that while both showed the active bleed in about the same number of patients, CT actually showed the cause of bleeding in more because, of course, you might have a tumor in the colon and maybe it isn't actively bleeding when you do the CT scan, but if you see the tumor there, then that probably is the cause. So they basically said, you know, maybe we should be really doing more CT in these patients and less red blood cell scanning. So to talk about the protocol, the GI bleed protocol, I'm going to bring you back to our abdominal timing diagram. And what we're doing here is a non-contrast study, a CTA, and then a portal phase, or it could be a venous phase, doesn't really matter too much. The reason you do the non-contrast study is these patients aren't prepped, and a lot of them will have hyperdense material in their bowel from something they've eaten or from the blood itself. And you need to be able to differentiate that from an active bleed. So that's your baseline. Then you have your CTA, and that's going to be your roadmap if there needs to be angio intervention afterwards, and it will also be something where you look for a blush. Then you do the more delayed phase to see if that blush expands or if you see pooling. And that tells you that the bleed is active, because in theory, you might see a little enhancing nodule on the CTA. Maybe it's an angioectasia, but it isn't necessarily actively bleeding. So having that second post-contrast phase helps differentiate from that. And it also can help make things much more conspicuous. I'll show you a case in a minute where that really helped make the diagnosis. So here's just an example, a CTA followed by the more delayed phase, and you can see progressive bleeding and progressive pooling there. And another patient who had florid duodenal hemorrhage. So non-con, you see nothing. You see near circumferential enhancement on the CTA, and then it starts pooling and moving dependently on the delayed phase. So this particular patient is what I was referring to earlier. So nothing in the non-con images. And on the CT angio, if I just had the CTA, I honestly don't know if I would have picked this up. So this was done on a fairly old scanner, no dual energy, no chance of doing low KV scanning on this person. In fact, you know, the scanner probably would have wanted us to do 140 kV. But you can see there's this area of hyperdensity in this loop of jejunum. And on the venous phase, it becomes very clear that that's active hemorrhage. But it was pretty challenging to pick up on the CTA. So I think the venous phase here really saved us and helped us feel pretty confident that this was the source of active bleeding. In this example, you can see there's a dependent hyperdense focus in the bowel, and the problem is if you don't have a non-contrast study, you're left wondering, is this something I need to be worried about, or is it just a piece of food in there? When you have the non-contrast images, you can convince yourself, okay, it was there before, I don't need to worry about it, it's just ingested material. So the acute GI bleeding algorithm for a few years locally has been this. So endoscopy generally is first, and then if there isn't something there that's endoscopically identified and treated, then they have a GI bleed CT. If that's positive, they'll either go to interventional radiology or surgery, and if it's negative, then we would consider an RBC scan. Since Nagata's paper, we've kind of been dipping our toe into this algorithm, and I know some other places are too, where people with acute lower GI bleeds, and I apologize for bringing the colon into this talk about small bowel, but they're kind of tied together. People would say, well, maybe do the GI bleed CT first, and then based on that, you can decide if it's something surgical, something that should go to interventional radiology, or something that should go to endoscopy. And then endoscopy would either deal with it, or maybe if they can't find anything, they get an RBC scan. So here's an example where we actually did that. Patient came into emergency and they were bleeding profusely, but stable. We did a non-contrast study. You can see on the CTA there's quite a bit of bleeding in that distended rectum, quite a bit more blood and pooling on the venous phase, and as you can see there is a fairly large tumor here, and it was a bleeding rectal carcinoma. Because we were able to identify this, the patient we were asked to take the patient to the interventional suite and embolize the tumor because apparently the patient was a medical train wreck. So by stopping the bleeding this way, this gave them time to stabilize the patient, normalize the creatinine, bring their pressures up, and reduce their anesthesia risk before they went to the OR a little over 24 hours later. I want to show one more case here. This is someone who had a rectal stump blowout, and you can see there clearly is an area of active extravasation in the region of the stump blowout, increasing on the venous phase. But I just wanted to make a comment about using dual energy in these cases. Again, I'm a pretty big advocate for either using low kV or dual energy when you're able to. You can get virtual non-contrast images from your dual energy data set. So the question is, are these good enough that you don't need to do the non-contrast direct acquisition? And the answer is, well, maybe. They don't look as good as the direct non-contrast images. I mean, as you can see here, there's some little artifacts. We're actually doing some research looking at following up stent grafts with dual energy. And one of the things we're looking at is when you do virtual non-contrast reconstructions, how often do you lose little bits of calcification? How often do you lose data when you compare a real non-contrast acquisition to a virtual non-contrast acquisition? And it does happen sometimes. And as far as I can tell, no vendor is immune from this. If you believe the literature, it sounds like the latest iterations of dual energy maybe are more protective against it, but it's not a perfect thing. So the question is, do you trust it enough to just do virtual non-contrast reconstructions? So far, I've been too chicken to do that, and we still do real non-contrast acquisitions. We'll see what happens in the future. But things like if I'm doing a non-contrast chest to look for intramural hematoma, I don't have the guts to do virtual non-contrast for that, and this is sort of similar. These are pretty sick people, so I feel it's fairly justified to do a real non-contrast acquisition, but things may change. And that's just talking about using dual energy. And then for the last part of our talk, I want to move into CT enterography. So we do a lot of these. We probably do 3-4 a day most days, sometimes more. And 10 years ago, most of our abdominal CTs, we were using positive oral contrast. In fact, that was the norm. These days, we've definitely moved away from that. We don't give very many people positive oral contrast. We'll still give it for extravasation, like post-op, perioperative patients. If you're looking for fistulas, or in cases where there's maybe a low-grade partial obstruction and the surgeon's wondering, will the oral contrast go beyond the transition point, because then I'll treat them conservatively for a little while longer. But the problem with the positive oral contrast is, of course, it obscures enhancement of the bowel wall. So it's never really been good for any kind of real bowel assessment if you're looking for a primary bowel lesion. And what you want to use is a neutral contrast agent. And in Canada, we have this problem where if we were in the US, you can get an agent off the shelf. In Canada, we can't because it's not Health Canada approved. So you can give people water, but that water is going to get absorbed well before it gets to the ileum. And the contrast agent in the US that I was talking about is Volumen. Now, they tried to get it Health Canada approved, but it was rejected. There were apparently some safety issues with animal studies, and they've never resubmitted it for review again, so we have no access to it. So I have tried almost everything under the sun, I think, for neutral contrast agents over the years. I tried whole milk when that was in vogue for a while, but drinking 1.5 liters of whole milk is absolutely disgusting. And so not only did almost nobody tolerate it, but even when they did, it barely looked any different from giving people water in my mind. So not great. Methyl cellulose is like drinking snot. So unless you're prepared to put a tube in and put it through the tube and basically do CT enterocolysis, you're not going to get anywhere with methyl cellulose. And to be honest, we do enough CT enterography, there's no possible way we could really add that to our workflow. Now, we did use sorbitol for a while, and sorbitol with locust bean gum our pharmacy makes for us, and that is still to this day what we're using for our MR enterographies. And it's not bad at all. I would say that lactulose might be a good solution. There was actually a paper in the CARJ a couple of years ago saying that of all these things I show you here, lactulose actually gave them the best distension, and they recommended it. And after I read that paper, I thought, well, this sounds great. I'm going to try lactulose for my CT enterography. So I called pharmacy. I said, I'd like to get some lactulose, please. I'm going to try this for my CT enterography. Later that day, I got a call from the pharmacist who helped me set up our sorbitol solution for MR, and he said, I'm just wondering what you're going to use this for. And I explained to him, and he said, do you have elderly or frail patients that ever get these? And I'm like, oh, yeah, I do, quite a few. And he said, it is not a good idea. We can't let you do it. We actually recommend actively against using lactulose on any outpatient. I said, why? And apparently the safety profile of lactulose is such that they get a very large number of people who get electrolyte abnormalities or serious dehydration on lactulose once they go home. So they've generally moved away from using it. They still use it sometimes in the people with liver failure, but in general, they really discourage lactulose, so they didn't want to let me use it. So I've sort of been left with polyethylene glycol, which is what we're using now, and has for many years had an excellent safety profile with us. I've had one patient in maybe 9-10 years that had quite a bit of diarrhea to the point where she did become dehydrated, and family ended up bringing her into the emergency room for rehydration. But that's one patient out of a few thousand, so it's been pretty safe. It is very well tolerated and gives pretty good distension. I still sometimes wonder at night what lactulose would be like, but I'm not allowed to find out. We have a fairly aggressive prep. Now, I will preface this by saying this is a prep for people where we're looking for a source of bleeding. So we don't make the Crohn's patients do a clear fluid diet for 36 hours. The reason we do this, and you'll see a whole bunch of different preps in the literature, but the reason why we decided to do for 36 hours, we kind of titrated it, and I will not tolerate having any particulate material in the small bowel if I'm looking for a source of bleeding, because then you never know if it's going to be a polyp or if it's just something that's ingested. And over thousands of cases, we found that they basically never have particulate material if you do this. So you let them have dinner and then nothing afterwards, and then the next day it's all clear fluids, and then NPO for 4 hours, and you're pretty much guaranteed that there's not going to be anything in your bowel. It's a little rough, I admit, but if we're really going to be serious about finding these lesions, I think it's probably necessary, and whenever we backed off on this, historically, we always ran into trouble. We give people metoclopramide when they come, and that does two things. It makes sure that the polyethylene glycol you give to them is going to reach the TI by the time you're going to scan, and it also basically means that nobody is going to vomit up the polyethylene glycol, and they practically never do. Like, it's incredible. So it really helps with them tolerating it, because we're giving them 1.5 liters over 30 minutes, and then another 250 cc's later on just to make sure there's stum in the stomach and duodenum. And one tip that I found many years ago was to chill it, and it's a lot easier to drink than if you have it warm. It's kind of gross if it's warm. And then, of course, we're injecting at high flow rates. I'm going to talk a little bit more about our injection protocol a little later, but I would say you probably want to do at least 4 cc's a second, and this is a theme here. If you're able to try and scan with low kV or dual energy when you're able to. Low kV, I think, is the way to go for these cases. Like 100 kV is probably good if you can manage that. So some of the indications we do this for: inflammatory bowel disease is huge. Recurrent obstructions, not so much. Suspected enteropathies, not so much, but we do that sometimes. And obscure GI bleeding is also a huge part of our enterography practice. The enteric phase, again, is going to be your arterial peak, say if you're doing a test bolus in the abdominal aorta, plus 20 to 25 seconds, so in that zone. So obscure GI bleeding is those 5% of cases that have proven GI bleeding. You've either seen it or the fecal occult blood is positive, but they've had normal upper and lower endoscopy. And some of the causes might be previously undiagnosed Crohn's disease, vascular lesions, small bowel tumors, enteropathies, not common for enteropathies, but sometimes, especially NSAID, and then Meckel's or small bowel diverticulosis. So that's what we're looking for. And a meta-analysis done in 2013 looked at how good CT enterography was for finding the source of bleeding in these particular cases. And the answer is, well, not great. It had about a 40% yield, but the main competition, capsule endoscopy, wasn't a whole lot better. It was 53%. But there was something interesting about this. They showed that the place where CT falls down compared to capsule endoscopy is for finding vascular lesions. But the CT was actually better for finding tumors than capsule endoscopy, especially polypoid tumors. So in a way, they're a little bit complementary. The vascular lesions we're talking about are divided into 3 categories. So you have your arterial lesions like AVMs, and then the Dieulafoy lesion. And what that is it's a little artery, and instead of constantly tapering as it moves distally, it starts to dilate or become aneurysmal. Angioectasias, which are these dilated veins, they can get fairly large sometimes and bleed. And then venous, like venous angiomas, which are really rare, or venous varices, which you'll sometimes see in someone who has portal hypertension. Now, the Mayo Clinic looked at that meta-analysis and said, you know what, then maybe we need to change what we do and to try and capture more of these vascular lesions if capsule endoscopy is seeing them and we're not. So they published this paper in 2013, which is a really interesting paper where they argued that if you're going to do enterography for looking for a source of obscure GI bleeding, you should really go all out and do a 3-phase exam, because they say, well, you're going to see the arterial lesions the most in the arterial phase. You're going to see the angioectasias in the enteric phase, and that's also where you'll probably see the tumors the best. And then the delayed phase is going to help you see the venous lesions. So they strongly advocated that people should have this multi-phase enterography. So what you would do is your first phase would be sort of an early arterial phase. If you remember from our prior slides, that had an empiric time of around 25 seconds. Probably what we want is something closer to 30 seconds. So instead of a TA, we'd probably do a TA plus about 5 seconds. And that's just to give time from the contrast to get from the vessel into whatever that vascular lesion is. So give it a little extra 5 seconds. Then you want an enteric phase and then a venous phase. So some of the things that you can see on these if you're looking for obscure GI bleeding, of course, adenocarcinoma. This isn't super common, but we see it every once in a while. Often it's annular, sometimes it's plaque-like. Very frequently the margins with the fat are irregular, and you also sometimes see a little bit of dilatation, especially when you challenge them with polyethylene glycol because of the stricturing. Neuroendocrine tumors, we actually see a moderate number of, actually. And just to remember for the residents, you know, if you see nodes like this, especially if they have calcium in them in the mesentery, you know, everybody's first thought is carcinoid. And you know, that's a good thing to think about. That remember, the carcinoid is not what you're seeing in the mesentery, that's the metastatic node. So if you see that, you have to look for the primary somewhere in the bowel. And frequently, if you look hard enough, you can find it. But they can be actually pretty small and have a lot of metastatic disease, so they can be kind of tricky. GI stromal tumors are something we see a moderate number of as well. They're frequently fairly vascular, fortunately, and they light up quite nicely on the enterographies, and they often have an exophytic component. This one here was actually incredibly vascular, and you can see the feeding artery and vein here, so it's no surprise that it had trouble with bleeding because those are quite juicy vessels. Lymphoma, GI lymphoma, I can count on one hand the number of times I've made this diagnosis where lymphoma was not already known. Pretty rare to just find it as an incidental finding, but this is one of the cases that we had where we diagnosed it prospectively before they knew that the patient had lymphoma. So you can have profound thickening, and sometimes you can have incredible thickening with no obstruction at all that surprises you because it is a soft tumor, of course. This was somebody who came to us for obscure GI bleeding, and they'd already had upper and lower endoscopy that was supposed to be normal. But we did our CT enterography, and you can see there clearly is an abnormality here of the gastric wall. So I actually talked to the gastroenterologist, and they decided to repeat the scope with endoscopic ultrasound, and then they confirmed the findings and did biopsies, and the patient had a malt lymphoma. And because it's a submucosal abnormality, it was just overlooked. You know, the stomach maybe wasn't optimally distended at the time and looked a little lumpy bumpy, and so you have to interrogate the stomach and the colon even though they've told you that the endoscopy was normal. This was a case we did for someone with intermittent small bowel obstructions, and you can see there's a beautiful intussuscepting lipoma here. There's some mesenteric fat going into the intersusceptum, and there's the lead point of the lipoma. Another patient, if you look at this closely, you'll see that there is a polyp on a stalk, and then you start looking and you see another polyp here, some polyps over here, something over here, and then there's just polyps everywhere. And this patient actually had, of course, a polyposis syndrome. You can see how packed their duodenum is with polyps here, which was really, really impressive. And again, just going back to my point that you can't assume that when they're telling you that the patient had a normal endoscopy that they really did. So these are a couple of cases where he picked up a gastric polyp, a frank gastric carcinoma that somehow got missed. I don't know if they didn't scope and they told us they did, or if something happened and the scope just didn't look at that part of the gastric wall, but that definitely does happen. The sensitivity of endoscopy is not 100%, and that happens in the colon too. So in this case, they thought they got to the cecum, but they didn't, and then on our CT enterography, we saw this pedunculated polyp and a cecal mass. So again, it's not the optimal test for the colon, but definitely take a look at it. Now, as far as the vascular lesions go, angioectasias often look like this. So they're these little enhancing nodules. And when they get big, you wouldn't be wrong for wondering if maybe it's actually a neuroendocrine tumor or some other kind of really vascular lesion, because they can really fool you. You know, as I said here, it's not, I can think of a few cases where either myself or my colleagues have called one of these big ones, you know, possibly a polypoid soft tissue mass like a neuroendocrine tumor. We weren't sure if it was a vascular lesion or not. The AVMs are often a little bit easier to tell that it really is a vascular lesion because they often have like a feeding vessel and a draining vein that you can identify, especially if you do some reformation. So here I just did a thin section MIP so you can appreciate that there's a tangle of vessels there that makes it a lot easier to find. This was actually from the arterial phase of a multi-phase enterography, although I still saw this on the enteric phase. These are a couple of high-flow vascular malformations that actually were called tumors. So one of my colleagues called this one, they thought it was, you know, a really vascular tumor, maybe a neuroendocrine tumor because it looked kind of mass-like, but it is really enhancing. If you look at it, it's actually enhancing like the common iliac artery. So that was probably the clue. And then I have to own up that this was my mistake here. I actually thought this one was a pedunculated, really vascular polyp on a stalk, and I didn't stop to think, gee, why is it enhancing as much as all the mesenteric vessels? And that actually ended up being a Dieulafoy lesion, and that was an aneurysm. So, but it looked kind of like a polyp, but I've learned my lesson. I really pay attention to the enhancement of these things now. So for the evaluation of obscure GI bleeding, this is our current workflow. So they get the endoscopy, they get CT enterography. Now that might find the cause. If it doesn't, you've at least screened for anything that might cause a complication with capsule endoscopy because you want to make sure there's no stricture present. You don't want the capsule to get stuck or to perforate. And then you may even proceed to push or spiral endoscopy. We only have one person that does this, so it is exceptionally difficult to get this in Winnipeg. I don't know if you guys see much of it done here.
What is that?
They will actually scope the entire small bowel.
Yeah, we have a double boarded push.
Yeah.
I think we have 2 people doing it now, but the waiting list is very long.
Yeah, because it needs to be done basically in essentially like an operating room, and it's a very resource intensive, very long procedure, so it's tough. You have to have not only someone willing to do it, but you have to have the resources to do it. So if you're doing the CT enterography, then I guess the question is, do you do a single phase or a multi-phase? And you might stratify that based on age, like say, well, the older people, maybe we can do a 3-phase study because the radiation isn't going to be as bad. Or do you do them all multi-phase like the people at the Mayo Clinic do? You know, I've had a lot of debates with other abdominal radiologists about what we should be doing for these. I've kind of settled on this, which is basically doing something like what I do for the ischemic guts. So we just do, again, a really long injection and get a combined CTA enteric phase. And I find that at least like arterial lesions show up really nicely on this. And I don't really feel like I'm probably going to miss one of these arterial lesions. And to be honest, the venous lesions, I don't think they're that hard to see if in the enteric phase. You know, most of the ones I've seen in my career tend to be small bowel varices in people with portal hypertension, and usually you can see those. So right now we've sort of settled into this pattern of doing a enteric phase single scan, but just with a lot of contrast to sort of help visualize the arterial lesions. I don't know if that's right or wrong, but you know, clearly there is some controversy out there about what we should be doing in the obscure GI bleeding cases. I have to say though, after doing multi-phase enterography on a number of cases, I did not find the yield to be impressive at all. In fact, I cannot recall a single case that I personally have read where I thought it added anything. And when I surveyed my colleagues before I made this talk a little while back, none of them could either. So I don't know. Are you guys doing multi-phase enterography at all? No, yeah. And then there's enteropathies. So things you might look for enteropathies on CTE is small bowel wall thickening or telescoping, you know, where the small bowel invaginates a little bit and then moves back, but it's not a frank intussusception. Changes in the fold pattern. That can be kind of tough to see. Jejunization of the ileum is one that we see easily, but it can be tough to say if the small bowel fold pattern is nodular or smooth on CT because there are limits to our spatial resolution. We're looking for abnormal wall enhancement, dilatation, ascites, and then mesenteric lymphadenopathy. So this is an easy one. This was someone with malabsorption syndrome, and they came in and they had a ton of small bowel diverticula. So that makes sense, bacterial overgrowth in the diverticula, case closed. Another patient where they had some malabsorptive type symptoms, diarrhea, sometimes they had obstructive-like symptoms. We did a CTE. And they had pretty classic findings for radiation enteritis that you know, became evident when we did a history and found that they had pelvic radiotherapy. You'll see that they also had previously undiagnosed hydro because of a pelvic ureteric stricture as well. The colon's also involved in that particular case. But things get a little tougher when you're looking at the real enteropathies. So here is a beautiful case of celiac disease, but I am under no illusions. I think most people with celiac that get CTE probably have normal or near normal exams because you have to be pretty severe to have significant changes. This case was previously undiagnosed, clearly pretty severe. They've got nodes, they've got telescoping bowel, wall thickening. I think it's a beautiful case showing the jejunization of the ileum. I mean, this should be pretty distal ileum down here, but you can see there's a ton of folds here. So very nice example of that. And then another patient with presentation of abdominal pain, weight loss and diarrhea. Same thing, very nice jejunization of the ileum. That's a really good clue. Lymphadenopathy as well and wall thickening. I really like this next case. This patient had food intolerance and hypoproteinemia, and we did this CT and they had a beautiful classic appearance of hidebound bowel from scleroderma. And as it turned out, they had a history of scleroderma that nobody told us about when they asked us to do the scan, but it was really nice to see that correlation, and I really like those pictures quite a bit. Very similar to what you would get in a small bowel follow-through or enema. This was kind of a weird case. we did this earlier this year. I don't know if you guys have seen the same thing, but we've had a ton of people just sort of cross over the border between North Dakota and Manitoba in the last year since Trump came in, worried that they might get sent back asylum claimants. And this gentleman was from Africa, and he'd come across the border and was having a lot of problems. Went to the emergency department, he had chronic diarrhea and weight loss. They did blood work that showed he was hyperproteinemic, he was mildly lymphopenic. GI saw him, and they asked us to do a CT enterography. And I don't know if it projects perfectly well, but the small bowel was a little bit hyper-enhancing everywhere. And you can see that there's this dilatation, this cystic dilatation all through the mesentery and the retroperitoneum. And I thought about this for a while, wondering, gee, that's pretty profound. It's probably lymphatic. I wonder what's going on here. And then it clicked that, he's from Africa. I wonder if it could be schistosomiasis. And he had a number of biopsies actually from various body parts, and he was absolutely riddled with schistosomiasis. It's not something I typically see in my practice, but it's just, that's the patient population. But it was the lymphatic dilatation, the history from Africa that sort of made me think about it. Clearly not something you're going to see every day, though. This patient had abdominal pain, weight loss, diarrhea, and fatigue, and I looked at this and I thought, oh, it's another bad celiac disease, because it looks like they've got, wall thickening and telescoping, lymphadenopathy. And I saw this and I thought, oh, this is jejunization of the ileum. So I called it most likely celiac disease. Typically when we say that, they'll do a small bowel endoscopy to do small bowel biopsies. And they did that, and it was giardiasis. So it made me go back and look at this. And then in retrospect, I started wondering, gee, is that nodular wall thickening? I don't know. And it made me think that, we really still have some limitations with this CT enterography, because the spatial resolution is just not as good as when we used to do small bowel enemas. I'm old enough that when I came back and started my practice, I was still doing some of those, so I remember how beautiful they looked and how well you could see the bowel wall. But we can, I think, see signs that there is something abnormal, and there's probably an enteropathy, but we shouldn't get too cocky about what that is. Now, I'm just going to very briefly conclude here by touching on Crohn's disease, and I'm not going to be head to toe about Crohn's or do an in-depth review. I just want to point out a couple things. So when we do the CTE again, we don't make them do that 36-hour clear fluid diet. And we do actually scan acutely ill patients as a CT enterography, but we don't give them polyethylene glycol, because if they've perforated or obstructed, that would obviously be a bad thing. But we do scan them like a routine abdomen, but we're scanning them in the enteric phase with the high flow rate. So it's our CTE scanning protocol without the prep, because it is really good for detecting enhancement and assessing activity of disease, and that's very often what the gastroenterologist wants to know when they're in emergency. And you have a lot of choices about what you can do in Crohn's patients. So some of them you might want to give oral contrast. Those are the perioperative patients. Ones maybe where you have a possible perforation, or ones like I alluded to earlier where the surgeon says, like they're low-grade obstruction, and if you can show me that oral contrast goes by, I'll keep them on the NG for a few more days. So we might give oral contrast for that, or if we're looking for a fistula. But really most of our CT on these patients now is going to be single-phase enterography. We do it very frequently as the first diagnostic workup, and then it's our acute presentation scan. So someone in emergency, we just scan them without the polyethylene glycol. And then we will use it as the follow-up studies in older patients who can't tolerate MRI. We still do a ton of MR enterography for this though, so we use that as the first test in younger patients just to avoid radiation, and it generally is our Crohn's follow-up modality. But single-phase enterography still has a really important role to play in Crohn's, and I would say for assessing for enhancement, you get such good studies uniformly. It is probably my favorite study to read for these patients. Another thing I want to talk about very briefly before we finish is the Society of Abdominal Radiology suggested nomenclature for Crohn's, because I think this is really good. My gastroenterologists really like it, and it makes a lot of intuitive sense. So unfortunately, there was going to be a white paper published about this, and it hasn't quite made it out. And there's only a couple of references in the literature to this if you're not like an SAR member going to the meetings. So it really hasn't disseminated itself a whole lot into the community. But it's such a great way of thinking about things because basically it posits that you start off with the active inflammatory disease without luminal narrowing, and at that point, that's the point where it's most easily treatable. And as you work your way down through active inflammatory disease with luminal narrowing, that's usually from edema, could be fibrosis, then into mixed stenotic and active inflammatory disease. So that's where you have luminal narrowing, but you have upstream small bowel that's greater than 3 centimeters. You're getting harder and harder to treat, and you're getting more fibrosis. Finally, you end up with fibrostenotic disease that really is mostly fibrosis and not inflammation, again, where you have evidence of obstruction. And the further down this pathway you go, the harder it is to get back to a normal scan. In fact, once you get to active inflammatory disease with luminal narrowing, it is hard to get to a completely normal study. Sometimes it happens. If you get to mixed stenotic and active inflammatory disease, it doesn't matter what you treat them with, they're really never going to completely normalize. They might improve, but they're not going to normalize. And then any of those can potentially convert to penetrating disease, but it's usually the ones that are either mixed stenotic and active inflammatory or the chronic ones that then reactivate. So there's a lot of things I like about this. It makes sense as to the progression of disease, and for the gastroenterologists, it gives them some extra information about how bad this is, how likely they are to respond to disease. One nice thing about it is the ones where you're typically considering surgery are usually these latter two. So the mixed stenotic and active inflammatory or fibrostenotic, because you're dealing with the obstruction. And the SAR disease focus group is saying, you know, what's really important here when you're assessing these ones is how much enhancement is there? Because if there's a lot of enhancement, that implies there's active inflammation that might be treatable medically. If there isn't enhancement, then maybe those patients are the ones who should go to surgery. So it's really focusing, you know, look for enhancement. And our ability to look for enhancement is so much better with a CTE than it is with just a routine CT, especially if you're doing a CT with positive oral contrast. So again, enhancement equals active inflammation. So just an example, this is a relatively mild case of active inflammatory disease which has some minimal luminal narrowing. That one could normalize if you treat it medically. And then a more severe case where there's quite a bit of luminal narrowing, obviously a lot of edema there, but there's no evidence of obstruction at this point. So active inflammatory disease with luminal narrowing is the category we'd put it in, versus this patient who has wall thickening, luminal narrowing, but upstream they're greater than 3 centimeters. So they're now in the mixed stenotic and active inflammatory disease. They're probably not going to normalize no matter what you do, but maybe if there's a component of edema there and not fibrosis, maybe that will open up if you treat them with maximal medical therapy. And then penetrating disease, some of the things you might want to look for are penetrating ulcers, fistulae, and intraloop abscesses. And I think CTE is actually quite nice for finding subtle penetrating ulcers that might have been tough to see just on regular scanning. I know this is a little pixelated, but if you look up here, this is actually the lumen of the bowel, and this is a little pocket where it's ulcerated, and you can see the enhancement outlines the ulcer. So it's kind of a harbinger of worse penetrating disease to come. And this patient actually already had a little inflammatory tag where you could see that if left untreated, that might become a fistula down the road. And these are two patients with fibrostenotic disease. Now, some would argue that fibrostenotic disease should not demonstrate wall thickening. I call this patient over here fibrostenotic disease because that patient did have surgery. They went to the OR, and I talked to the pathologist, and he said it was probably the first Crohn's resection he had seen where there was virtually no inflammatory cells in the specimen. Even people who, you know, have been labeled with chronic fibrotic Crohn's strictures, they typically still have some inflammation. It's very rare to completely get inflammation go away in Crohn's, but that one was. And then this is sort of more of a classic fibrostenotic area. It just never opens up, and that was actually present on a couple of different scans, so we were able to catch that one. It can be kind of tricky though. When the wall isn't thickened, you have to sort of differentiate, is that just spasm? Because remember, you've given people polyethylene glycol, so you might get a little transient dilatation. If you have multiple scans, it's a lot easier to tell. And then this was kind of a nice case, someone who had recurrent obstructions from Crohn's, but it wasn't necessarily the disease activity waxing and waning. They just had an enterolith in there because of the chronic stasis, and it would periodically plug the stricture and then unplug. Now, if you look at this person, you can see their strictures do have a little bit of enhancement there, a little bit of mucosal enhancement, but the vasa recta isn't really that active, and most of the bowel wall is not actually enhancing that much. So probably a lot of this is fibrosis, and not a whole lot of it is related to active disease. And then one final thing is, remember that you can get little nodules and masses in these things, and very often it's just inflammatory pseudopolyps, but these people are at higher risk of malignancy, so you have to be a little careful. So with that, I will bring this to an end, and just to remind you, for ischemic gut, the key thing you want to think about is consider doing a combined CTA enteric phase for your first phase, followed by the venous phase. The GI bleed is going to be a 3-phase study, non-con CTA, and then a portal or delayed phase. And then for enterography, the enteric phase is the key one. Whether you want to do the arterial and venous is kind of up to you, but you have to have good neutral oral contrast. And then if you remember that SAR Crohn's lexicon, that's great. We're trying to push it and promote it because I think it's actually really good. If anyone has any questions, feel free to email me there. These are my kids. They're quite cute, and they like to dress up and act a little bit. So that's my youngest daughter. She's 7 now, and that's my middle daughter, who's now 10. They like to help me out with my presentations. So thanks again, everybody. Really appreciate you coming out and listening to the talk.